All right, good evening, everyone. Welcome. On behalf of the San Diego Liver Coalition of San Diego, we are honored to have you join us tonight. We extend our sincere gratitude to our dedicated medical partners, healthcare professionals, and community partners whose continued commitment helps advance education, awareness, and compassionate care for those impacted by liver disease. My name is Chaplain Dr. Neshea Harrison. I am the new board president for the San Diego Liver Coalition. And I'd ask that if you have not checked out the YouTube channel, if you would just go subscribe, share with those that you know who want information in regards to liver awareness. It is my privilege on tonight to introduce tonight's distinguished speaker, Dr. Yuko Kono. She is highly represented gastroenterologist, a hepatologist, and a professional of medicine and radiology at UC San Diego. She specializes in liver health, liver cancer, liver cancer care, transplantation, and advanced imaging, and is recognized for her expertise in guiding patients through every stage of liver disease treatment. So, if you would, please join me in warmly welcoming Dr. Yuko Kono.
Thank you so much. So this is the Liver Coalition um, pictures. Thank you so much, Dr. Harrison, for the kind introduction. Good evening, everybody. So I'm Yuko Kono. I'm going to be talking to you about liver cancer today. And here are my disclosures. So here are the outlines about today's talk. So I'm going to talk about screening and surveillance, who and how, diagnosis of HCC, staging of HCC, and how to choose treatment, and then when to send patients to transplant centers. So first, let's talk about HCC screening and surveillance. So what we're going to be talking today, liver cancer, we're going to talk about primary liver cancer, and it's also called hepatocellular carcinoma, HCC. I will be, saying HCC a lot in this talk. Hepatoma is also another name. Now, there is other primary liver cancer. It's called cholangiocarcinoma. This is a bile duct cancer. I'm not talking about cholangiocarcinoma today. And there are other liver cancer, secondary liver cancer, basically the metastasis from other type of cancer, such as colon cancer, breast cancer, lung cancer. We're not talking about those metastatic or secondary liver cancer today. HCC is a pretty common cancer, and it is a majority of primary liver cancer. About 75 to 85% of primary liver cancer is an HCC. And in the world, it's over 800,000 new cases a year, and more than 750,000 deaths per year. You can see the new case and the number of the deaths per year is very close. It's a deadly cancer, and it is the third leading cause of cancer-related death worldwide. And overall, HCC 5-year survival is still pretty low, about 20%. And you can see in this world map that China has a lot of HCC cases. We have pretty medium orange. And then Africa, China and Africa are mainly hepatitis B related HCC. Now in the States, they estimate in 2026, so over 22,000 new cases and then over 30,000 deaths is the estimation. Now, in the United States, it is increasing in incidence and also mortality. On the left-hand side slide, you can see all cancer, the green line is overall declining. And the blue one is lung, it's declining. Pink is breast, it's declining. Colon is also declining. Pancreas is slowly going up a little bit. And you see this orange line. This is a liver cancer. It is going up. On the right-hand side, you can see incidence and mortality both are going up and then slightly downtrending, but it is overall increasing cancer in the United States. What are the risk factors? Cirrhosis of any etiology and chronic hepatitis B with or without cirrhosis. And major risk factors, those hepatitis B, hepatitis C cirrhosis, they're big HCC risk, alcohol and MASLD, and the fatty liver disease. These are risk factors. The trends are that viral hepatitis related HCC are declining versus MASLD alcohol related cancers are increasing. And talking about fatty liver, we have in America, 60 to 80 million Americans with MASLD and 15 to 20 million people with MASH. This is a more advanced form of this non-alcoholic fatty liver disease. And then they develop fibrosis and cirrhosis. And cirrhotic patient will develop HCC, although it's not as high as hepatitis B or hepatitis C related cirrhosis, 1.5 to 2% per year. But there's this red line, right? So these fatty liver patient, it's a very, very small portion of this patient, but they could develop HCC without cirrhosis. And that's a big problem. We don't know how to screen these patients. And it is, many people are looking for how to stratify our screening for these fatty liver disease patients. But right now, guideline is that cirrhosis patient will get screen surveillance. Now, so this is a guideline for the HCC screening and surveillance. And it is recommended in risk groups. Any patient with cirrhosis, the threshold incidence is 1.5% per year. And all the cirrhotic patients qualify for this incidence, threshold incidence. And specific hepatitis B carriers, and so without cirrhosis, right? Threshold incidence is lower because they don't have those other comorbidities like cirrhosis. So it's a little bit different population. And per AASLD guideline, Asian male older than 40 years old, female older than 50 years old, African, North American Blacks, family history of HCC, these patients have a higher risk of HCC among these hepatitis B patients. And what do? We recommend ultrasound and AFP, that's a tumor marker, alpha fetoprotein, every 6 months. And when we do ultrasound, we recommend using live rods. And you may or may not have heard about live rods. Usually, we use it for HCC diagnosis with CT, MRI. It's a standard imaging diagnosis, which I'm going to talk a little bit later. But also for this surveillance ultrasound, we have ultrasound live rods. It's basically standardizing the reporting, including not only there's a nodule positive, but also visualization score, basically a quality of ultrasound. Because as you may know, ultrasound quality can be very variable. And if you have, really big patient with BMI 40, or, there's a lot of bowel gas, there are lots of factors that can make ultrasound quality poor. And when the visualization score is poor, it's C, we can't really trust ultrasound. The sensitivity goes down really low. So we do recommend using this Lyra's template to not only talk about positive findings, but also the quality of ultrasound. And then we also recommend, in the guidelines, they only recommend AFP, but we also have other tumor markers, such as AFP total and L3%. This is a fractionated L3 AFP, and DCP, that's desgamma carboxyprotein. These are FDA-approved testing, and it is not that expensive, and it will basically support ultrasound fairly low sensitivity, about 60%. And if we want to get a little more better testing, that's my personal recommendation. Now, so if we do those testing and then we see something, how are we going to diagnose HCC? What do I order? So if ultrasound and or AFP is positive, we need to go for imaging. It's a contrast enhanced CT scan. We usually do triple phase or quadriphasic phase. It's a multi-phase scan or dynamic enhanced contrast MRI. Usually MRI is always multiphasic, or contrast enhanced ultrasound if it's available in your institution. And basically the key point is we need contrast and we need multi-phase imaging. We need this arterial phase, portovenous phase, late phase to diagnose HCC. And one phase, just venous phase CT scan cannot give you diagnosis. And we can also use tumor markers. It's not necessary diagnosis per se. It's also can be negative. That doesn't mean they don't have an HCC, but when it's high, it's useful. Now, I want to talk about LIRADS a little bit. This is a liver imaging reporting and data system. It's created to standardize liver imaging reporting and the diagnosis. And the liver cancer, or HCC, is a very unique cancer that if we apply this imaging criteria for patient at risk for HCC, so you can't apply to everybody, but you use it for cirrhotic patient, for hepatitis B patient. Then when these imaging criteria meet, and then we have this DIDAS 5, this is a definite HCC. So you can diagnose HCC by imaging only without biopsying. Again, this is a very unique cancer and with almost 100% probability. And so the LIRADS have all these numbers, right? LIRADS 1 to 5, M, TIB, all these things. What it is basically LIRADS 1 is a definitely benign lesion. And from LIRADS 1 going up to 5, probability of HCC increases. LIRADS M is a different category. It's likely malignancy, but not specific to HCC. So we are thinking of cholangiocarcinoma, metastasis, and some HCC, particularly differentiated HCC, can be in this category. And therefore, LIRADS M has to be biopsied. LIRADS TIB is a tumor invasion, it's a vascular invasion, so it's a more advanced cancer. So LIRADS, again, it's a liver imaging reporting and data system. It is an imaging diagnosis for HCC on high-risk patient. LIRADS 5, it's an HCC, no biopsy needed, and we can send the patient to treatment. LIRADS 4, this is the probable HCC. It's about 70 to 90% probability, so it's very worrisome lesion, but we cannot diagnose HCC by imaging only. So we recommend multidisciplinary discussion at the tumor board, and the management can be variable. LIRADS M, like we talked about, it is a malignancy, but not necessarily HCC. Cholangiocarcinoma, metastasis, and HCC can be in this category. So we typically need a biopsy for diagnosis. Let's look at some imaging. So this is a LIRADS 5 lesion on the MRI. On the left-hand side, it's a non-contrast MRI. You see a very subtle hypointensity lesion in, I think it's segment 7 or something. It's 21 millimeter. And then in the middle panel, this is the arterial phase. So that lesion is enhancing. So this is aorta, it's enhancing in the arterial phase. Now, you see other things, right? Okay, aorta, IVC is enhancing its vessel. These are portal vein. But then what about those little things, right? Are they all cancer? So, you don't just look at the arterial phase, you look at other phase. So there are all those things. But then if you look at the portal venous phase on the right-hand side, that lesion, that enhancing is now darker, right? It's called washout. And also there's a kind of thin rim enhancement. It's called capsule. And these are the major features of HCC. When we see this AFI, arterial phase hyperenhancement, washout and capsule, this is meeting a criteria for LIRADS 5. So this is a definite HCC. Now, these other little things is now disappeared, right? It's a homogeneous enhancement in the portal venous phase. So these are not a cancer. So it's really important to have all those different phases to diagnose HCC. And then there are other findings like on the left side, this is nodule appearance. Middle is mosaic appearance. These are very typical, typically seen in the bigger HCCs. And then on the right side, you see mosaic appearance, and then that's nodal nodules. These are now metastasizing to the neighborhood. So these are HCC. Okay, then when do I order liver biopsy? Liposome, like we discussed, definitely need a biopsy, almost always needed. Lidas 4, this is a very worrisome lesion, right? But we cannot diagnose HCC by imaging only. And but then management can be variable. We may want to biopsy, we may want to do different things. For example, Lidas 4 and patient can be a liver transplant candidate. We need a definitive diagnosis. We may be biopsying versus, patient already have an HCC. We are already treating. And then there is a 1.5 centimeter new Lidas 4. It's an HCC. We don't have to prove it. We can just treat it. Or if it's a small lesion, we may monitor. So we do recommend multidisciplinary discussion at the tumor board. And then Lidas 5, we don't need a biopsy for diagnosis, but can be done, especially for molecular profiling. Our oncologists would love it because we will have more information. And we do have a lot of systemic therapy options, which I'm going to talk about later. But, some patients go through all the immunotherapy, TKI, everything, and then we don't have any more options. But wait a second, you have HER2 mutation. Then, you can use breast cancer treatment. Actually, I have a few patients actually on HER2, breast cancer medication, and they're working. So sometimes, this can be very helpful. And then tumor in vein, sometimes we're not sure, HCC or chondro, we may biopsy. Now, Lidas 3, we didn't talk much about Lidas 3. These are intermediate risk, right? So it's in the middle. But it's actually 50%, well, depending on the data. Some data 36% up to 50, 60% of probability. And especially if it's a large Lidas 3, we may want to biopsy because it can be an HCC as well. Okay, and so now we have a diagnosis. What do we do for staging? What do I order? What do I care? So HCC staging, number one, we want to have a very good CT scan or MRI with a multi-phase scan, like we talked about, to know how many HCCs, how big, where there are HCC in this liver. And then we want to know, of course, outside of the liver, lymph node, everything. And then we need a chest CT. Typically, we only need non-contrast CT scan, chest CT for HCC. Why? Because HCC is a hematogenous metastasis. So usually it's a peripheral small lesions in the lung, and contrast doesn't really help. What contrast helps is a lymph node. So in the mediastinum, if there's a contrast, then we can see the lymph node better. So it's fine to have contrast, but most of the HCC don't really need a contrast. So without contrast, it's fine. Now, if you're doing abdominal CT scan with contrast in any way, then I would order chest CT with contrast because we'll have more information. So that's a chest CT. Now, how about bone scan? We used to do a bone scan all the time. Now in ASLD or NCCN guideline, they took out the bone scan because it's very rare. We may order it. It's optional. For example, patient has new shoulder pain or bone pain, or AP is going up, and there's nothing in the liver or chest. So we may want to check the bone. So sometimes we order it, but it's not necessary for everybody. Now, how about PET CT? Some oncologists will be ordering PET CT. We do not recommend it. Why? Because it's pretty low sensitivity. It's about 50%. And then negative doesn't really mean much. And also spatial resolution is not great. It's really not helpful. So we do not order PET CT. Now, we also need a liver function and performance status and why it's for staging, right? We'll tell you why it's very, very important for HCC staging. Now, this is the T stage for HCC. You don't need to remember all this. Just don't worry. But most thing important, if you want to remember one thing out of this T stage, just remember T2 stage. And why? Because when we are thinking about liver transplant, we're going to talk about this. This is really important. So what is T2? It is one nodule, 2 to 5 centimeter, or 2 or 3 nodules up to 3 centimeter. It's called also Milan criteria. If the patient is a transplant candidate, they will get the exception points for the transplant and they can get to transplant pretty quickly. So if you want to remember anything, it's a T2 stage. Okay. So that's a Milan criteria. And basically, if 5 years survival post-transplant is greater than 70%. Okay. Now, T1 stage is basically smaller than T2. So it's only this one lesion less than 2 centimeter. Now, this is very important. Stage T1, we cannot get the points for transplant. So if the patient needs a transplant, we do not want to treat it because we will lose the opportunity to get to the patient to transplant. If we treat that the T1 HCC, then patient cannot get the point. So we sometimes get the referral from outside institution. And yeah, we found 18 millimeter HCC, we treated it. Yeah, can you transplant the patient? No, we can't. We have to wait till the patient develop another HCC. So, it's good to know. All right. And then, so that's a T stage. It's very important for the transplant purpose, especially this T2 stage. Now, we often use this BCLC staging, and this is Barcelona Clinic liver cancer stage. And it's a very busy slide. I don't expect you to read everything. I'm going to blow up the first part. And so you can see from left side, it's a very stage HCC, single HCC with a good liver function, performance status, very early stage. It's curative. It can be curative. To early stage, to intermediate stage, it's a multifocal HCC. And then advanced stage is a portal vein invasion, extra hepatic spread, metastasis, liver function pretty good, performance status maybe a little bit 1 to 2. So it's a little bit different, more advanced stage. And then the terminal stage, is any tumor burden, any stage, basically end stage liver function. Liver function is really poor, performance is poor. So here in the terminal stage, there's no tumor size, right? There's no tumor size, even if the tumor is 2 centimeter. If the patient is dying from liver disease and they're not accounting for treatment, then it's a very different story. That's why liver function will determine not only the tumor stage, liver function performance status will determine the prognosis and also treatment options. And we'll talk about treatment options. Okay. And then, so again, this is a busy slide. So we talked about up, and then they kind of provide first treatment option. And then below, basically we can move around. So if we progress, then we go for systemic treatment. For example, we can also downstage the patient to transplant or, even resection. So it's a kind of more complicated. It's not very simple. And that's why we recommend multidisciplinary discussion for all these treatment options. Okay, so now how to choose treatment. This is a big talk. If I want to go really, this is alone, I can talk about this for hours. So this is just a brief introduction so that you have an kind of idea of how we are choosing those treatments. Okay, so let's go back to BCLC staging. It's a little different picture. Now, so early stage cancer, it's a small tumor burden and also very good liver function. We're going to try to cure this cancer, right? So the surgical resection, liver transplant, these are the curative options. We are always thinking, is this patient a candidate for surgical resection or liver transplant? Okay. Now, even though it's an early stage, whatever reason, maybe heart is bad or, the different the reasons, they may not be a surgical candidate or transplant candidate. Then, for the small lesions, microwave ablation, radio frequency ablation, these can be curative. Also, a tear, transarterial radioembolization, can be curative. So we do nowadays, a modern tear is with a very, very high dose radiation. When we studied tear, it was kind of equivalent to TACE chemoembolization. Nowadays, we do it very differently. With a very high dose radiation, it's an ablative therapy. It's like it can be equivalent to resection. And so it can be a curative treatment. Okay, now next is the intermediate stage. And so in this, figure, they only listed chemoembolization. It's a little bit old. Now we do chemoembolization, we do radioembolization. We can also do system therapy, and we do have also combinations of system therapy plus TACE or system therapy with, we can do all those things. Now, we can downstage these, more tumor burden to say GT2. Then we could potentially send the patient to transplant. So palliative, the intermediate stage, it's usually we think it's a palliative treatment, but we could potentially move it to curative stage. Now, next is advanced stage. So it's a system treatment. Okay, so what systemic treatment do we have? We have now multiple options, and thanks to all the development for actually 10 years, 2000, I think 7 to 2017, I think we only had Nexavar, sorafenib. That was it. But now we have multiple immunotherapy, TKI, we have clinical trials. So patient has a lot of options. Current first-line therapy is atezolizumab, that's a PD-L1 inhibitor, bevacizumab, that's VEGF antibody, and tremelimumab and durvalumab. This is an immunotherapy combination. It's called STRIDE regimen. And then Ipi and Nivo, this is also immunotherapy combination. And then we have clinical trials. So we have, different first-line systemic therapy. And just to brief, atezobev and durva, the STRIDE, how do we choose these? Main thing is because of bevacizumab, that's a VEGF antibody, we can't use it for patient with like bleeding risk, thromboembolic risk. So if patient has varicose bleed or tumor bleed or something else, PE, we can't use this regimen. And it requires upper endoscopy, EGD, before treatment. On the other hand, this STRIDE regimen with the tremie durva, we don't have to worry about bleeding risk, so it doesn't require EGD. So these are the main difference. It's every 3 weeks versus 4 weeks, and there are some other differences, but that's the main thing that we look at it when we are going which treatment we go first. And then there are other first-line option, durva monotherapy, lenvatinib, that's a TKI. Sorafenib is almost gone. Nobody uses it. It's too much side effects. It's hard to use. And then lenvatinib is, it's actually, we think it's better, although the study was non-inferiority study. And then this tislelizumab, sorry, it's approved only in China, but somehow NCCN guideline listing this medication. It's not approved in the United States. And then it's immunotherapy, and then it's a Pembro and a clinical trial. And then second line, cabozantinib, regorafenib, ramucirumab, and nivolumab, the TKIs, the immunotherapy, these are second line treatment options. So advanced stage, of course, we think it's a palliative. Can we cure these patients? Well, there are some successful cases. Like we had cases with horrible tumor in vein, all over the entire liver, all the portal veins, tumor in vein. After 5 years, we don't see anything with the immunotherapy. And, there are some people, whether intentional or not intentional, patients of therapy and doing well, that we are seeing more patients. It's still very minority. We're not going to tell the patient we're going to cure this disease when they have such an advanced disease, but it is possible. We've seen, and then I think we'll see more, of those amazing response, amazing cases. Now, we can also downstage with system therapy. It's possible. We've transplanted some patients with a huge HCC advanced case. We downstage with immunotherapy plus minus local regional therapy. And then we did successful liver transplant. They're doing well. So that's possible. Although we need to be careful about selecting patients. And the immunotherapy prior to transplant, although we're going to stop immunotherapy, it can increase the risk of rejection of the transplanting organ. So we usually wait washout period about 3 months at our institution. Some other institutions have different protocols, but it's very important. And we did have, like in the early days, we did have a patient who I don't remember actually how long, maybe 3 months washout period with an nivolumab. She was treated with at other institution and got the transplant. And this patient rejected the organ so severely that we did everything. We did steroid, thymoglobin, plasma ferrosis, IVIG. We did everything we can think of. We lost the organ, and she had that second transplant, and we still tried to reject. So we did everything, and then the second organ we saved. So she's doing fine now, but that can happen. So we need to be a little bit careful, but we've been successful, and there are more institutions doing this, and there are more data coming. But we really need to be careful, because if we transplant the patient and if the patient recur HCC, we no longer have immunotherapy option. Well, we could do immunotherapy post-transplant. That's like really, really high risk for causing rejection. So we usually don't do that unless, we're so desperate. So again, there are more data with immunotherapy post-solid organ transplant, but we do not recommend. So we are limited to TKI, tyrosine kinase inhibitors after transplant. So we really need to make sure this patient, we're going to cure HCC and the cirrhosis by transplanting. And that's, that's the kind of careful patient selection. Okay. Now, so then when should you send the patient to transplant centers? So again, there's a T stage. Now you remember T2, right? So T2 stage, one lesion, 2 to 5 centimeter, 2 or 3 lesions up to 3 centimeter. So these Milan criteria can get exception points for the transplant. So we always think about, well, this is T2, can we do transplant? Now, this MELD score, I'm not expecting you to know all this, but basically this is a model for end-stage liver disease. Initial MELD, at the top is the initial MELD score. We only needed creatinine, bilirubin, and INR. And then we added sodium level, it's called MELD sodium. And then most recent MELD score, it's called MELD 3.0, have gender, bilirubin, sodium, albumin, INR, and creatinine. So there are lots of things we put it, and then this spits out the number. It ranges from 6 to 40. And we use this because this is a risk of 90-day mortality. The higher the patient sicker, they're going to die within 90 days, right? So when the organ's available, we're going to offer the liver to the sickest patients waiting. So MELD 40, we'll go to the MELD 40 patient if they can go down. And, currently in our region, we are transplanting about MELD 32, 33, something like that. That's a medium MELD. And if the HCC patient, if they have T2 stage HCC, they're gonna get this median MELD at transplant -3. So it's about 29-30. They have to wait 6 months after being listed, but they get this big MELD point. Their biological MELD may be 11, right? Then they're not competitive with the other MELD 30 patients. But if they have T2 stage HCC, after 6 months, you have to be stable, you have to stay within T2 stage, they can get these points and they can get to transplant usually within a few months. Now, again, we talked about T1. If we treat T1, then they are not going to get the exception point. So if the patient needs transplant, they have already portal hypertension complication, variceal bleed, ascites, liver function is kind of poor, they need a transplant, and a reasonable candidate, psychosocial candidate, then do not treat. We usually monitor T1 stage HCC. Usually we image every 3 months. The moment it hits T2, either 2 centimeter one lesion or 2 lesions, both like less than 3 centimeters, 1.5 centimeter HCC, 2 of them, it's T2. So we'll wait till the moment T2, then we start treatment. T3 or T4, like we talked about, we can be downstage. So we don't give up. We try to send the patient to transplant, because that's a cure for both HCC and the cirrhosis. And, it's the best treatment option if patient can have it. Not everybody can have it, but if we can get the patient to transplant, that's the best. Tumor in vein or spontaneous bleed of HCC, these patients are not the candidate, but you could still do it if patients get all the treatment and stable, no signs of cancer outside the liver at least for a year, then we can ask for points. We have to send the narrative and stuff, but that's possible. Distant metastasis, unfortunately, not a candidate, even if they're doing well. That's in contraindication. Okay. So yeah. But if you're not sure and the patient is a reasonable candidate for transplant, please send the patient to the transplant centers for the evaluation. Okay. So to summarize, here are my take-home messages. HCC is the most common liver cancer, primary liver cancer, 75 to 85%. It is a third cause of cancer death in the world. So it's a pretty, it's important, significant cancer. It's the fastest growing cause of cancer death in the United States. And the risk factors, cirrhosis and hepatitis B. And those patients need surveillance. Now, screening is a one-time test, right? Baby screening for the genetic testing, these are one time. These patients with cirrhosis, chronic hepatitis B, it's a screening and surveillance. You have to repeat it every 6 months. Some patients, oh no, I already had the ultrasound. No, that was 6 months ago. You have to do it again. So that's every 6 months, okay? And then diagnosis, we talked about multi-phase, phasic contrast imaging, CT, MRI, or contrast ultrasound. And we use live rods for diagnosis. That's 5 is an HCC. Biopsy, it can be done or should be done when imaging is not diagnostic or molecular profile. Now, treatment options, we talked about early stage HCC. We're gonna aim for cure, right? Resection, liver transplant, ablation, hair, radioembolization can be curative treatment. Intermediate stage, TACE there is usually we use. We can also do system therapy. Advanced stage, system therapy, but we nowadays have those combination therapy and it's not clear cut. Intermediate stage, we may be doing systemic therapy. Advanced stage, we may be doing system therapy. Plus, like one lesion is kind of growing. We'll do TARE for this patient, the ablation for this one lesion if other lesions are responding. Okay. And then multidisciplinary approach is very important for the best patient care. Now, I just wanted to advertise a little bit our group. So this is a HCC multidisciplinary team at UCSD. We have actually a clinic together. And so on Wednesdays, we have clinic in La Jolla, Kansas, HCC, no, Moore's Cancer Center. And on Thursdays, we have a clinic at the Hillcrest Cancer Center. It's in MOP, it's a new building. And we have medical oncology, Dr. Burgoyne and Dr. Kuo and I are from hepatology. We have surgeons, Dr. Welling, Forrester, Shinico, and intervention radiology. Dr. Roman Minocha are the main, but then we have other intervention radiologists as well. Radiation oncology, Dr. Simpson, and diagnostic radiology, Dr. Sherlin, Santian, and Max. And so we work together and we do tumor board together. And yeah, if even if you don't need it's UCSD care, if you are wondering about imaging diagnosis or kind of multidisciplinary discussion, just send the patient. We can also just present at the tumor board for treatment option recommendation as well. So that's my talk. Thank you so much for your time. And I think we go for Q&A.
There we go. Thank you so much, Dr. Kono, for that. It's very informative. And if there's anyone who has some questions and you want to go ahead and drop them in the chat, we do have some questions that were sent in via registration. And one of the questions was about, let's see here, reversing fatty liver.
Mhm. Yes, thank you. Thank you for the question. So we didn't talk about a lot about, we talked a little bit about fatty liver, and this is the most common liver disease worldwide nowadays. Of course, there's alcoholic liver and fatty liver, but I think probably, people are thinking of non-alcoholic fatty liver, muscle or MASH, we call it nowadays, metabolic associated associated liver disease or steatotic liver disease or steatohepatitis. So risk factors for MASLD MASH are obesity, high blood pressure, high cholesterol, and diabetes, and plus minus alcohol. So basically, we need to treat weight loss is the really it will if patient lose weight, we usually recommend 5 to 7%. Greater 10% is definitely will resolve MASH or fatty liver. Of course, alcohol, you stop drinking alcohol. And for the weight loss, of course, we have beautiful GLP-1. You guys know Wegovy, Ozempic, Mounjaro, Zepbound. These work great, right? Of course, patients should work on diet and exercise. We have also medication, the resmetirom, and that's approved for MASH, muscle D MASH, and that will also work. So that basically weight loss is the key for the resolving fatty liver. It will get better. It will, if patient lose greater than 10% of that weight, then fat will be gone.
Okay. The second question that was presented was, what is the best prediction of liver disease progression? And how do we as patients best understand our disease progression?
Okay. Great question. So again, we didn't talk a lot about liver disease. We kind of focus on HCC today. But so basically disease progression, when we are talking about disease progression of liver disease, we are thinking about fibrosis. So there are, disease activity, which is usually we look at the enzymes, SGLT, alkaline phosphatase. That's like how much inflammation, activity is happening. But then these activities, inflammation will lead to fibrosis. And that's what we care. When we talk about disease progression, staging, we are basically talking about fibrosis. Now, how do we look at this fibrosis? In the past, we stick a needle, biopsy. Oh, you're F1, F2, F3. That's what we did. Nowadays, we have a lot of tools. We can do blood tests. I don't know if you guys heard of, there's an APRI score, FIB4 score, ELF, fibro test, FibroSure, fibrometer. These are the blood test-based testing. So they will give you some idea of where you are on this fibrosis score. If 0 is nothing, if 4 is cirrhosis. So it's, so you kind of have an idea. And then we also have those non-invasive testing, elastographies. BCTE is also called FibroScan. It's an ultrasound-based test, no imaging. It's a vibration, kind of we send ultrasound signals, and then kind of measure what's coming back. Ultrasound basically travels faster when it's hot, that the tissue is hotter. So fibrotic liver will get kind of faster kind of return. So they have a way to measure that. So they will kind of give you an estimate, your liver's normal or some fibrosis or cirrhosis. And we also nowadays have shear wave elastography. That's a regular ultrasound-based elastography. So we now we can order shear wave elastography when we do, for example, HC surveillance for hepatitis B patient. I may be ordering shear wave, and that will also give you the estimate of fibrosis. And then we do have MRI elastography. That's also with the MRI, we can do the estimation of fibrosis. Now, as a patient, you should just talk to your doctor. What about my liver? What tests are you ordering for me? Where am I in my disease progression? But these are the tests your doctor may be ordering and maybe talking about, well, your liver is normal, no fibrosis, or I'm concerned you're maybe F1, F2 versus, your advanced F3 or F4 is cirrhosis.
Okay, thank you. We also have two other questions. What is the risk of cancer for those who have had hepatitis C but have been cured?
Okay, great question. And if patient had a hepatitis C and already had cirrhosis, right? Whether very well compensating, no symptom, or like ascites, a lot of symptoms. It doesn't matter if the patient had cirrhosis at the time of cure, you will carry the risk of HCC for a long time. What we don't know is how long, so right now we'll just continue until we're cirrhosis all gone, you don't have a risk, right? So that's what we do. Now, if you did not have cirrhosis, then depending on the fibrosis score, if the patient didn't have any fibrosis, hepatitis C is cured, you basically do not have risk to develop HCC. It's the same as other patient with no fibrosis. So that you don't have to worry about risk. Now the gray zone, also the other gray zone is, well, what about F3 or advanced fibrosis close to close to cirrhosis but not quite cirrhosis? And it's debated. And also, it also matters, well, I have hepatitis C, that's cured, but I also have fatty liver disease. Then that's also the liver disease can progress. You may carry the risk of HCC. So these gray zones, again, please talk to your doctor. And one thing I want to say is I had some really sad cases. The hepatitis C is cured, patient had cirrhosis. We want the patient. I tell the patient like many, many times, listen, your liver test is normal now. You're totally functioning. Your liver is working 100%, but you have cirrhosis. You carry the risk of HCC. You have to come back every 6 months to do screening. And patients are like, oh, I feel fine. I have no liver disease anymore. 6 years later, like big cancer with tumor in vein, and it's really, really sad. And so make sure if you do, and then that's the other thing, hepatitis C, we will make sure what's your fibrosis before we treat, because the numbers will be totally normal, right? And after treatment, but if you had the secret cirrhosis, then we have to continue HC surveillance. So it's really, really important. Talk to your doctor again. What's my fibrosis? Do I need a screening after cure of my hepatitis C?
And are cases coming to you in later stages, early stages? Are younger people showing up for screenings now?
So you mean the for the hepatitis C or HCC?
HCC and hepatitis.
HCC, yeah. So HCC, we get all kinds. I get very early stage, I get very, very late stage, all sorts of the diagnosis. But it tend to be if the patient is either not diagnosed with cirrhosis or not getting surveillance testing from outside referral, they get symptomatic and then tumor in vein, metastasis, it's very sad. Versus patients getting, standard care from GI, hepatology, wherever they are, and they're getting those screening surveillance every 6 months, they may find, well, there's a single 2 centimeter HCC. Can you resect? Can you transfer? Right? So we have all sorts of patients, but we still have a lot of advanced disease, advanced HCC, and also younger patients. We do have younger patients, and I think it's across actually, like colon cancer, breast cancer. We see a lot of younger patients, and I don't know what is like really, happening, but we do see a lot of younger patients as well.
Extend our heartfelt appreciation to you on tonight for sharing your time, your expertise, and all your valuable insights on this topic that is not as, I like to say, it should be exposed a little bit more, but it's kind of hidden under the leaves a little bit. So thank you so much for your time on this evening, and I can't wait till we can do this again.
Thank you so much.